Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hello, welcome back to Unraveled, Understanding Complex Illness. I am Eileen Ruhoy, and I'm with my lovely co-host,
David Kaufman. Hi.
We are going to talk today to each other, and you can eavesdrop in, about HPA, the Hypothalamus-Pituitary-Adrenal axis. You know, a lot of people think that A is the axis, but it's not. It's the adrenal gland, and then you have to add the axis. It's like the HIV days.
Right.
You know, they used to say HIV virus.
Right.
And then there was this whole thing, I remember in like the newspapers, like, why do people say that? The V is the virus. But the A in this case is actually the adrenal gland.
HPA
So it's not
axis.
the axis, yeah.
Okay. So let's hit the road.
Yeah. So this is the major axis. And I will say that we find a lot of abnormalities of this axis in our septad patients. And I think largely because obviously it starts with the hypothalamus, which is sort of this master gland, and it sort of controls this entire axis, but it controls a lot more, right? So it doesn't just control, of course, the pituitary and the adrenal glands. It controls, I mean, I don't know why the thyroid gland is not in there, by the way.
Well, it should be.
Yeah, it should be.
I mean, I consider it part of that.
I do
the
too.
The problem is that that word A for adrenal is added to the HP, and that messes it up.
I know. And then no one went back and said, we should have a T in there.
It should just be hypothalamic-pituitary axis.
Right. It should be.
Yeah.
The A should be the axis. Right. You're right. Regardless, we see a lot of abnormalities. You know, again, I think there's a lot of reasons for it, and we can sort of pontificate to all the different reasons. But a lot of our patients, you know, develop CCI, intracranial hypertension, sometimes intracranial hypotension. They have abnormalities of their sella turcica, which we sort of talked about during the IIH episode. And, you know, I think that affects the pituitary gland. And of course, there's a major feedback, both negative and positive, between the hypothalamus and the pituitary gland. And that just sort of affects the entire axis. Right. And so we see a lot of abnormalities. And I refer to it as the neuroendocrine axis because that's sort of how I see it, because a lot of this have neurological effects, but they're largely endocrine effects. And a lot of endocrinologists deal with these particular disorders, especially when they're disorders of the pituitary, like a prolactinoma example. I see a lot of elevated prolactin.
And I don't understand it.
Well, I'm curious about your thoughts about this, since we were just talking about mast cells. You know, mast cells also release dopamine, right? And you know, dopamine and prolactin have an inverse connection. And so I've been trying to sort of decipher if this is related to mast cell activation, because I cannot figure out why there's elevated prolactin. You know, in conventional neurology, you see elevated prolactin post-ictally, like after a seizure. Yeah. And then, of course, a lot of our patients have seizure-like episodes. So, you know, early on in when I was dealing with chronic and complex patients in the septad patient, like this was my first thought. Like, okay, are there subclinical seizures going on? You have these weird movements. You have these weird events that you're describing. Are these seizures? And so I would, you know, this is sort of was my thought process with regards to the elevated prolactin. And then I started thinking, and then I started to realize it's not. Though it still sort of sits there sometimes in some of the patients that I see. So I really have given this a lot of thought and trying to understand why. And then it was just sort of like, well, there's abnormalities of the neuroendocrine system because this patient clearly has IIH, what we now know is not to be idiopathic, but, you know, elevated intracranial pressure. And but then I started thinking about the mast cells and the dopamine.
It's a great idea.
Yeah.
Great thought. I mean, I order prolactin, I get it back elevated, and I sit there and I think, why did I order this? And now what do I do? And
you did it because you're looking at the pituitary.
And it's almost like something intuitive in the back of my head said, oh, check the prolactin, but then I'm not sure what to do with it.
Yeah, so here's what here's what I've done, and this is why I think that I'm onto something, and now you are too. Yeah. I've given dopamine. And I've checked dopamine and they're low. It's low.
How do you give the dopamine?
Cinnamon.
Very interesting.
Yeah.
All right. Let's pull ourselves back a minute to the endocrine HPA.
I know. We're going
this is our style.
Yeah.
Okay. I know. So
these were our coffee dates. Remember during the pandemic? This is exactly how it went.
Right. So important to tell everybody or emphasize we are not endocrinologists.
No,
at all,
I'm not an endocrinologist.
And the problem with that is the endocrine systems, hormonal systems, play a huge role in our patients. And frankly, I've had great difficulty getting endocrinologist help on this. So I've had to try to learn it on my own.
Mm-hmm. Okay. Same here.
So I think it's fundamental concept that people need to understand, and I think most people do, but just to be sure, the endocrine system is the ultimate example of a negative feedback loop system, meaning you have stuff up here that tells something here or here or here to make hormone levels, and then the stuff up here senses the level of the hormone and tells these organs to cut down on their levels. So it's a negative feedback. So high levels promote decrease here. These are the stimulating hormones and vice versa. Oh, is that sounding clear?
Absolutely,
Okay.
It does.
And that's the basic concept in a lot of endocrinology. Okay.
Right.
For reasons that are not clear to me, and I have my own thoughts as to why, we can go into it. In our patients, there is often a dysfunction of the HPA axis, or we'll just say HP axis, okay, where that feedback loop is screwed up. And the problem is not what we usually have been taught is the location of the problem, which is in the hormone-producing organ or structure. It's in the orchestra leader, the conductor, okay? This is the conductor and this is the orchestra. And the orchestra is working fine. The conductor is not doing his or her job, not sending the proper signals, in this case, specifically to the adrenal glands. And so it's an important concept which most endocrine doesn't buy into, okay? So
I agree.
And it's hard. I've tried to refer for help, and they just ultimately roll their
I agree.
eyes.
I think endocrinology as a specialty has taken each gland and has sort of decided the parameters that sits around that gland. And if it's outside of the parameters, it's abnormal. If it's inside the parameters, it's normal. And there's no gray area. It's very black and white.
Right.
And what we know in these patients is that there's a lot of gray area. I've had patients who where every gland seems to be malfunctioning.
Yes, absolutely.
And and there's this whole argument, and I don't really know where I stand in terms of like the proper terminology, frankly, and maybe you can help enlighten me a little bit, because I know you work with the adrenal gland a lot more than I do. But this whole idea of adrenal fatigue, adrenal insufficiency, I mean, my endocrinology colleagues take great issue with these terms.
Right.
But when I think about the chronic fatigue that our patients have and the post-exertional malaise, I can't help but think that there is some component of the adrenal glands that's contributing. And why isn't it just insufficiency or fatigue?
So this is not something that I'm making up or you're making up. Just to be clear here, this is not our anecdotal experience in the office or clinic. It's well proven and well documented with paper after paper after paper that patients who meet the criteria for ME/CFS, almost every single patient has a disorder of the hypothalamic-Pituitary-Adrenal axis. And every paper will say we're not sure why.
Right.
Okay. So if endocrinology doesn't acknowledge that, that doesn't mean it doesn't exist. Okay, which is actually that probably should be a poster for complex disease. Okay, the concept. I, as part of my initial workup in virtually every single patient, will order a saliva cortisol level. All right. I also don't like the term adrenal fatigue, by the way. I just wanted to make sure I could say that.
Good.
And I used to roll my eyes in my New York days and my stupid days at the idea of saliva cortisol, because that's what endocrine taught me. Endocrinologists mostly don't believe in saliva cortisol levels.
That's right.
I have learned, and now I'm a total believer, saliva cortisol measures free cortisol. Blood cortisol levels measure total cortisol. Total cortisol is made up of free cortisol and protein-bound cortisol. Free cortisol is the active form. Protein-bound is inactive. 90% might be protein-bound, 10% is free. You're not learning much by looking at that total cortisol, number one. Number two, very rarely do you ask a patient to stay in the lab and get 4 tubes of blood drawn 4 times in the day, including bedtime. They'd have to sleep at the lab, okay? So saliva, you do 4 times a day, morning, noon, roughly morning, noon, 6, and bedtime. We'll come back to what to do with our patients who don't sleep normally, okay? And you get 4 numbers, and you put them on a curve, and we know what it should be. It should be highest in the morning and gradually taper down to lowest at night. That's 1,000,000 years of evolution right there, okay? Our patients, virtually without exception, I mean, maybe I'll have one here and one there, will have a 50% or more below optimal level and then flat. And mostly they're just a flat line.
Mm-hmm.
Okay. And I challenge any endocrinologist to tell me that's not significant when the patient also says it takes me 3 hours to get out of bed in the morning.
Right.
Okay. If I measure the ACTH level, it looks normal in a lot of those patients.
Mm-hmm.
Something is wrong with the conduction, the messaging system to the adrenals.
Right.
And the fact that I don't understand what it is doesn't mean I shouldn't address it.
Right. But in the neurological world, it makes so much sense to me because there's something called apraxia, right? Where the brain is sending the message, but the receiver of the message is not getting it. And the axis also has nervous system signaling.
Right.
So it's basically what you're describing. So it makes sense to me. And I wish that someone who understood these glands on a more biochemical, molecular level, like an endocrinologist, can just sort of embrace this idea and help to figure it out.
I'd love to not be doing. I'd love to refer all these patients, honestly, but I can't.
Right. But you're right. So they all have some level of a dysfunction of one of the glands. And I even find with the exocrine glands, like I even find pancreas issues in some of the septide patients. So, which is an exocrine organ, so not technically an endocrine organ, but just the glandular function, I guess is what I'm saying. Overall.
And that's important to keep emphasizing, even though we said adrenal, because you're right, absolutely right. We find a lot of patients with thyroid abnormalities, again, where their T3 and T4 will be at the lower end of the normal range,
mm-hmm.
and the TSH will be at the lower end of the normal range.
Mm-hmm.
That is not normal.
I always say that about TSH, by the way. It's such a wide range.
Yes.
And, and unless you've gotten TSH levels done when you were well, which no one ever does, of course. I mean, I guess some people, some PCPs might do it as like a screening.
Maybe for older patients.
Right. You don't really know what's normal and what's not normal for you because that range is so wide.
And there's a big argument about normal in that range.
Right.
So there is definitely literature, papers, and discussion. So the range is 0.4 to 4.5 in general. I think that's what it is, 0.4 to 4.5 for TSH. Okay. So as a PCP and an internist, I was taught you want to keep it in that range and generally in the like 2.5 to 3.5 range. Okay. Partly because we were taught if it's too low, that implies there's too much thyroid hormone circulating, and that's going to cause osteoporosis. That's the mantra that was drilled in for the boards. Okay. So there's a lot of discussion that that's a ridiculous statement, keeping TSH at 3. We really want to push it down to 1 or 1.5 because we need higher levels of thyroid. And I find that's true in our patients. Thyroid is a potently metabolic hormone. It controls our rate of metabolism, our sense of hot and cold, our heart rate, our nutrition. I mean, it's huge, and works, by the way, in link with adrenal function and cortisol function, which we'll come back to. So I will treat that. All right, and of course the endocrinologists, if they see this, get very upset. Okay, we got off topic a little.
Well, I have patients, I was going to say, that have like low T3 or low T4, and they are given medications to raise it, like levothyroxine, but it doesn't raise, it doesn't go up, and so there's some central abnormality, is my point. Right. It's not just correcting at the glandular level, is what I'm finding, and I don't do a lot of it. A lot of them, their PCPs are doing it, or as you know, a lot of our patients see like naturopaths who are really good at thyroid management. But regardless of the management, it's not being corrected at the glandular level. And so there's a central component to this. And it just goes back again to what you've said, which was so like articulate and insightful on your part, which is that there's a problem with the conductor is not conducting well enough, right? So,
and that may be from infection. It may be autoimmune.
Absolutely. Lots of
inflammation.
Reasons.
I think it's probably, as we keep coming back to, a link to mast cell activation. Intracranial hypertension flattens out the pituitary. I mean, it's takes two to tango, hypothalamic and pituitary. So if the pituitary is crushed by the intracranial pressure, you got a problem. Right.
No, exactly. So that was that's one of the causes that I see of abnormalities of the HP part of the HPA axis. But I'm sure there's lots of reasons, that we have dysfunction of this axis, right?
Well,
so it's not just
probably occurs more occultly than we realize. Meaning
for sure.
intracranial hypertension.
Well, as you already mentioned, the low cortisol. I mean, so not all these patients have IIH.
But they may. They may have it comes back to what's normal.
Right. No, exactly.
We're going to get way off topic here,
I know we're going to get really way off topic.
You're the neurologist, so you should be saying this. In the intracranial hypertension world, if you do a spinal tap to diagnose it, the cutoff is 25?
No, it's lower. It's 22.
22.
22, okay. 23.
So that means if you have one of our patients and they do a spinal tap for some reason, which I'm not advocating, and it comes back 22, most of the time the doctor says, oh, you don't have any problem. 22 is the upper end of normal. And if they also have HPA axis problems and everything else, they might have a problem.
Right. So I don't really mean to be off completely this topic, but these normative values are BS for this patient population, because they've been sitting in such an abnormal state of production of CSF and absorption of CSF for so long that I think their arachnoid granulations and I think everything about the volume compartments of their central nervous system are functioning differently, that I don't even apply normative values to them anymore.
And that statement, I love the way you use
I'll
that
leave
word,
it there.
Normative value. I love that. Applies to everything we're really talking about with respect to these hormonal systems. Okay. So
I'll even say that Dr. Bolognese, when he's got the bolts in, he's like, well, they're borderline high. And I'm like, that's not borderline. That's abnormal. Because this patient, he agrees with me, but he wouldn't argue with me. Anyway, that was completely off topic, but I had to throw that in there.
No,
but back
this
to the
is on topic. So, and just to keep this going in the sense of not just adrenal, same discussion applies to testosterone. Mm-hmm. Testosterone is
I know nothing about
hormone,
testosterone.
the growth hormone or the stimulatory hormone, whatever you want to call it, comes from the H and the P, and in a man to the testicles and in a woman to the ovaries to make testosterone.
Right.
Women have testosterone too. Most of my female patients are often deficient in testosterone. Both sexes need to be checked, okay? And in the same way I mentioned free cortisol and saliva, if you just measure total testosterone, you're going to get back a combination of free and protein bound, and only free is the active. So you can get, I just had a patient the other day, their male patient, total testosterone was about 600, 650. That's smack in the middle of the range, which is roughly 250 to 1200, I think. His free testosterone was, I don't remember the exact numbers, the range is roughly 8 to 16. His was 4. Okay? So if you only did total testosterone, you say, oh, you're crazy, you're fine, you don't have any problems. But he does have a problem. Mm-hmm. And replacing testosterone matters. In men, it makes them tired, it makes them dizzy, it can make them depressed, obviously it can cause sexual dysfunction, impair muscle synthesis, et cetera, and all the same things in women. Okay, so it's a crucial part of this HP dysfunction. Boy, have we gotten off HPA. All right, let's go back to HPA.
But these are glands. I mean, and these are all endocrine functions that we know play a role in the septat patients and their symptoms, especially in the ME/CFS patients. I mean, so it's just the fact that, and we don't have do we have endocrinologists on our listserv?
I was hoping when I posted my question about ACTH stimulation test, but nobody's responded. So
well,
no endocrinists responded.
Right, and also I noticed with the estrogen conversation going on right now.
So we got to get
those are really important. I mean, but those are important hormones in everyone's body, and because they play so many roles. It's not like a hormone and a role, right? Every hormone has multiple roles, and that's what's so important. They interact with each other. I know, exactly. So it's such an important component to treatment of these patients that we need to figure this stuff out. And if we have to figure it out on our own, then I guess we will.
Really, which is, I confess, what I've been doing for the last 10 years.
Right. So do you replace cortisol? Do you do hydrocortisone?
Okay. So I get that saliva cortisol back. I review it with the patient, and I'll usually say, turn into a little bit of an actor for this. All right, well, here's your curve. It's very low and flat in the morning, and then it gets worse and worse. And to me, this is a curve where I would think the person would experience the following. They wake up, and it takes them literally an hour to get out of bed, another hour before they can get downstairs and eat anything, and maybe by 11 o'clock, they're starting to feel better. And the patient looks at me and says, shit, that's exactly what my day is like. Okay, so I do replace, all right?
Yeah.
And my conceptualization of this is I am not doing hormone replacement, which is usually the term used for somebody with no thyroid gland. You hormone replace to physiologic levels. I'm doing mini replacement, sub-physiologic, okay? So I'll usually start with 5 or 10 milligrams of hydrocortisone in the morning. ask the patient, let me know how you feel after a week or two. Do you notice a benefit? And if you do or don't, when does that benefit wear off? Because the half-life of cortisol is about 4 hours. And usually they'll say, yeah, I feel better. I can get up and now I'm out of bed at 9 o'clock instead of 11. But by noon, I feel like crap again. Okay. Well, that's not surprising. It's a curve. So I will then add a lower dose. Maybe if I'm started at 10, which I don't usually start at, maybe the noon dose will be 5. The normal production of cortisol in us, if we're healthy, is roughly 25 to 30 milligrams a day. That's if we're not having, not sick, excuse me, not septic, haven't been hit by a car, haven't had a huge fight with our partner, haven't just taken the board exam and terrified you failed. Okay, so this is normal calm state. So I'm very comfortable replacing, from 5 milligrams up to 15 or even 20. That should not cause side effects. It shouldn't cause weight gain. It shouldn't cause the side effects of steroids that everybody gets frantic about and is worried about when I say we're going to do this. It's a sub-physiologic dose. It is not a pharmacologic dose. It's not even a therapeutic dose in a sense of using the higher doses. Okay. The downside of this, as you get up above the 20, is that you may end up putting that HP to sleep with regard to the adrenal. Your pituitary thinks you have enough, so it decreases ACTH level, which is the hormone that stimulates adrenals to produce. The adrenals don't get the ACTH stimulus, so they say, oh, cool, I'm going to sleep. I've had it. I'm taking a break, going on vacation. And then they're not going to respond if you need cortisol because you were hit by a car. And so, I always have to warn that, yes, you have to warn the patient that you might run into trouble. I've never seen it happen at 20 milligrams, but certainly if we get up to 25.
Right. Yeah, I've definitely, I do the same kind of protocol that you do, and I definitely stress dose. So if there's an infection, and in fact, during sort of the COVID years, which is still going on, of course, but any of these patients that got COVID, I would give them more because they would sort of succumb to not having enough steroids to sort of help fight this infection.
Right. So I'm assuming when I do this that the patient, before I give them hydrocortisone at any rate, has an intact and functional adrenal gland. That's the orchestra. Okay. But I'm less sure the flatter that curve is. So if I literally get back a curve that starts here instead of here and just stays and then gets flatter, I am concerned, could they have actual full-blown true adrenal insufficiency?
Right.
And then I would do an ACTH stimulation test, which is a test where you take ACTH in a pharmacologic dose, the stuff that the pituitary makes. You draw baseline cortisol and aldosterone level and ACTH level. You give them their ACTH shot, and 30 minutes later, you measure cortisol and aldosterone. And there's an algorithm, a formula of how much that ACTH should kick the cortisol levels up. And if it doesn't do that, then they actually have full-blown adrenal insufficiency, and they need to be on full dose replacement, which is roughly 30 milligrams.
Do you do any of that genetic workup that there's a lot of like the CYPs, those variants that can contribute to like adrenal hypoplasia or hyperplasia?
I don't, but I do worry about the CYP SNPs that can increase the metabolism of cortisol. So when we're treating infections like Bartonella and we're giving rifampin, rifampin upregulates a SNP that more rapidly metabolizes hydrocortisone, and so I will preempt that by actually adding hydrocortisone.
Interesting.
Yeah.
So that's another question. So any of the antibiotics that you use to treat infections, are any of them toxic to the adrenal glands on any level?
You mean directly toxic?
Yeah. I mean, is that a concern about some of those antibiotics?
Not that I can think of, other than their effect on certain SNPs.
I only ask this question because obviously, I don't do the antibiotics like you do. I get a lot of patients who've been on IV antibiotics for years, and they all have adrenal insufficiency. Not proven by the ACTH stim test, as you just described, but what I've been referring to is adrenal insufficiency, or because I don't like to use the word adrenal fatigue because it's been so ridiculed.
I don't like
so I don't say it. So, and I always wondered, was it the antibiotics? So I'm just actually asking you.
Yeah, I don't think so, except for this issue with this CYP, and I can't remember which one it is. I learned this from Bob Mazziani, and I can't remember right now which SNP it is.
SNP.
But along those lines, and along the lines in general of HPA axis, is what we said earlier. Generally, if there is a HPA axis dysfunction, which is my preferred term to avoid adrenal fatigue, I will look very closely at thyroid and consider replacing extra thyroid as well, because these two hormones work together so much together. In fact, it can in true crisis, if you fix one without the other, it can be a disaster. Not relevant to our patients so much as a true adrenal insufficient who rolls into the ER or something.
And how do you think this plays into what I often find to be patients have hypoglycemic episodes? So in terms of glucose metabolism, how is that playing a role, do you think?
Yeah, it's a great
because as you know, this is sort of like the glucose tracking is sort of the new kid on the block, right?
Exactly.
I've now the continuous glucose monitoring, I have been prescribed it for just about every patient I've seen in the last 6 months.
So I haven't been doing it. I learned about it from you. I follow a podcaster who talks about it all the time. And it's clear to me that in a lot of these patients, there is, like thyroid, testosterone, and cortisol, a potential problem with glucose and insulin function, which makes sense.
Totally makes sense. Absolutely.
But
cortisol plays a role in glucose metabolism as well.
Absolutely.
So, it might not even be the insulin.
So I haven't done the CGM monitoring the way I should, and that's kind of on my list. If you look at my computer, I have all these stickies on the bottom, and that's one.
Very often reported are nighttime episodes of hypoglycemia. Right. Not symptomatic necessarily, so it doesn't necessarily wake them from sleep. They just sort of see it on their tracker when they wake up in the morning. So they're not symptomatic, which is interesting.
Right, and that may be because of their low cortisol.
That's
what cortisol does. It raises your sugar.
That's so interesting.
Physiologically,
so fascinating.
Everybody thinks of it as a toxicity causing diabetes, but it evolved for a reason. Cortisol.
Right. Oh my gosh, there's so much at play here.
Yeah, exactly.
And I feel like we can see the connections. I just can't grasp it just yet. So I think we have to explore these things more. But
the glucose is really important.
The glucose, I think, is, incredibly important, right? Because every cell needs glucose. Right. So I think that's a really key molecule that we have to understand more about its metabolism in these complex patients. Because I think it's similar in the sense that it's playing a critical role that we're not acknowledging, and it could find us new avenues of treatment, right? Which is always our goal.
Yeah.
Right?
So this will take us even further off.
Okay.
Potentially off topic. Okay. So the glucose issue, basically, another way to discuss this is insulin resistance.
Right.
Okay. Insulin resistance is now felt to be the major cause of chronic inflammation and the diseases of aging. Mm-hmm. Okay. Inflammaging. I'm sure everybody's heard that term because it's always in the papers now. And I am kind of working in my brain on this idea that our septad patients, our ME/CFS patients, and our long COVID patients are basically, I don't know how to say this without upsetting people, are patients who are experiencing premature aging because of ongoing chronic inflammation causing their inflammaging.
I don't think they'd be upset. I think they feel it. I think they know it.
Insulin resistance is crucial to that concept.
Yeah, for sure.
Okay, and
which is the whole reason why you and I even started looking at the regenerative therapies to begin with.
You steal my thunder here.
Sorry.
And I was that's okay. I do it to you. And I was just about to say, and that's why I've been experimenting, trialing with patients, giving things like low-dose rapamycin and exosomes and metformin, because those are drugs which impact the glucose intolerance and insulin resistance and inflammation.
But the key difference, and this is sort of off the topic of the HPA axis at this point, I mean, really off the topic, but I think a critical point to make. The key difference between what the longevity people are looking at and what our patients are facing is that the longevity people will tell you that physical exercise is key to slow down aging. But our patients can't exercise. In fact, I am so bewildered by this very important distinction that I have reached out to exercise physiologists that I know and have asked this question, like, would you engage in a conversation with me about this very important distinction? Because I think that understanding why these patients can't exercise because of the fatigue and the malaise they feel after they do can give us insight into why exercise is so helpful for longevity. Right. But no one will have that conversation.
And it's a double-edged sword, because the flip side of what you're saying is the fact that they can't exercise further promotes their inflammation.
And then further promotes, by the way, adrenal insufficiency, right? Yes. So it does go back to the HPA axis.
The literature on the value of exercise is absolutely overwhelming. So just
but our patients can't exercise. I know. But I think that's where you find answers.
Yeah,
like when
I
you
agree.
sort of take the complete reverse of what you know to be true.
Right.
And if you understand that at a deeper level, you learn so much more.
Yeah, I agree.
And it can only help our patients.
Right.
And I really wish that some of these exercise and fitness experts and longevity doctors, and I think that if they look at our patient population and try to understand what happens to them when they exercise, that they feel so horrible, I think there's going to be greater insight.
I mean, I think we both feel, and you know way more than me about this, that the cause of this, the root cause, is mitochondrial dysfunction.
Oh, without question.
And if you look at Bob Navio's models, the cell danger response models, that it fits in perfectly. And again, back to the aging, the pillars of aging, diseases of aging, inflammaging, that is all based on mitochondrial dysfunction. And that's the point of all these regenerative interventions, including exercise. Exercise increases mitochondrial efficiency and even mitochondrial biomass. Yes. Okay, I'm all into this idea of zone 2 exercise, which makes you get bigger, better mitochondria.
Exactly.
Our patients desperately need better mitochondria, but they can't do zone 2 even.
Right, exactly. So the simplicity, and I've thought of that. And the simplistic, I mean, it's easy for me to say, well, the mitochondria doesn't have the supply to give. And that's why they feel worse after they exercise. So there's an inherent problem with the mitochondria, which, we've all suspected. I mean, right. Yes, I've suspected for a long time, but there's been a ton of conversation. And I talk to Bob Navio all the time about this, and he agrees, but to get down to the sort of the nitty gritty about what exactly the deficit is, right. No one really knows just yet. And how to treat it.
We use all these supplements. We put supplements in, they probably just come out in the pee. It's so frustrating.
I know. I have a new mitochondria protocol I have to share with you, though.
Okay.
Yeah. It's fairly extensive, but I did a lot of research on it.
Okay.
And
maybe we should have a separate episode just on mitochondria, because then we can talk about the oxaloacetate.
I would love that.
Which I think is really important.
That's a great idea. That's our next episode. That's a great idea, actually. Okay. Well, I think we're out of time, actually. So we're gonna have to now wrap it up. Anything
I think we may have confused people more than
I'm sure that this was all over the place, more so than we usually are.
Yeah, it is more.
Well, because you can't talk about something that regulates so many things in the body as the HPA axis does, and not touch upon these things because our patients are so complicated and have so many things going on. So I think it was a hard thing to stay on topic for, but we'll come back to it, I promise.
And we need endocrinologists.
We need endocrinologists for sure.
All right. Thank you very, very much. Please write in your questions. We read them and we try to answer them, and we will devote other episodes to your questions as well.
For sure. Thanks again.
Thank you.
Bye.